So my next question would be to him on that you had been treating a lot of pneumonia and ARDS, viral pneumonia in particular with the ARDS. Do you think we have got some unsupported news? So I want to listen it from you. That do you think this particular novel related pneumonia and ARDS is behaving in a different way?
I think we need to see more from personal experience to be able to see that. But what's been said in the literature so far is that once these patients are intubated, the initial compliance is not that bad always. However, certainly they are taking longer to come down on FiO2 or PEEP compared to the normal influenza pneumonia. What we are seeing in the numbers that we have seen so far, or with talking with colleagues, that they are staying on a double-digit PEEP for a longer time than influenza pneumonia, and as soon as you start reducing the PEEP, they de-recruit quite easily, and therefore you are seeing that in day 6, day 7, they are still on a PEEP of 10, 12, or even higher, and FiO2 is coming down at a much slower gradient. But compliance itself may not be that bad. But there is another group as well, small group, which has a much lower compliance, stiffer lungs, and they are much obviously difficult to ventilate. So there are 2 or 3 different variations possibly, which is emerging. We have to see in the wider literature what comes out, because our individual experiences are obviously constrained with the number of cases that we are seeing right now. But what is sure is that they are taking much longer to come down on FiO2 and PEEP. And they are needing proning and reproning, lots of proning sessions.
Okay, so regarding that, I was just coming into it. So you are telling that one is the compliance may not be different, but a little bit of stiffness is expected. They are staying up quite a lot on a higher PEEP and also FiO2, higher FiO2. So are you NHS itself practicing proning and reproning? I will come to that. But before that, are you guys recruiting? Are you using any recruitment maneuver?
As we know that there is no one recruitment maneuver that is better than others, and therefore if you keep PEEP high enough, that is usually good enough for this patient so far, that in the numbers that we've seen, plus talking to others. You don't have to recruit hugely, and one other thing is the secretion burden is not that high initially. They have got mostly dry lungs. It's not a patient where you are suctioning a lots of mucus in the first few days, and therefore if you can keep them PEEP high, that is usually good enough. And then proning is obviously very helpful. But what's happening is you prone for a couple of sessions, you put them back again on supine position, and they're needing much higher oxygen again very quickly. So they're probably needing more sessions of proning. We'll see what comes out in the larger literature in terms of how many proning sessions on average each patient needed. I think what's important is that a large multi-center trial is started to see how these patients behave across the board, because our individual experiences will vary depending on what we practice individually. And also, I think what we have not seen or thought so far is the ethnic variation in pathophysiology and disease activity and how they behave. For example, how the Chinese behave may completely vary in terms of how a Caucasian behave or how an Indian patient behaves. So it's important that that factor is taken into account, and I don't think that I've seen anything yet on that count. It will be really interesting in terms of pathophysiology.
Okay, we'll come to that part maybe in a couple of months. But what I need to know from also you, that we all know that proning is definitely good for any ARDS patient. It has given us a mortality benefit. It sounds pretty simple, but in terms of when you are really short of the PPE, short of staff, trained staff and all others, so how practically it is difficult to prone a patient as well as reprone, and how long you are keeping those patients on a proning position?
if a unit is practiced enough, proning should be, not that difficult. We, for example, every now and then our unit and lots of other units practice proning in simulation suite, and any new staff that comes, nursing staff, they get a practice of how to do proning properly, and therefore with practice, proning becomes part of ICU life. And it's not another huge intervention that people get worried about. You just prone as if it's your normal. So what we are trying to do now is, instead of making proning a different timed intervention, say we are doing a ward round, we are timing the proning with the ward round, so that we are already there with our PPE on. So we don't have to use another set of PPE if we come back into prone in 2 or 3 hours time. Then you have wasted.
Okay,
we are timing the PPE proning
that's an
procedure when you are
that's
going
an interesting idea. Is that if you are proning when you are there. So in 2 ways: one, you are able to monitor how the things are going, as well as you are also providing a helping hand the scares and scared nursing people to do the proning part. I really appreciate that. And how long you are keeping them in a prone position at a stretch?
16 hours, 16 hours would be our standard. Sometimes we go slightly over, maybe 1 or 2 hours, but definitely we wouldn't put them supine within 12 hours. 16 hours is a standard. In some obese patients, which we have done in the past, we certainly have in our unit have proned a patient who was nearly 230 kilogram at one point. What we have seen is obese patients need longer proning. If you put them in supine position, their FiO2 doubles very quickly. So we should be prepared to keep them prone for longer if needed. It may so happen that you prone and then you put them on their back and they're desaturating very quickly in half an hour. It may be that next time 16 hours comes and they're they're prone and they're still on FiO2 of 70%. I would be fairly happy to keep them prone longer, another 8 hours, 12 hours, as long as their pressure areas are fine, their eyes are fine. Conjunctival and eye edema.
So we can conclude that there is nothing special in terms of proning, only a little bit of manpower, and you are tying up with the ward rounds to save multiple different hands, and as well as to monitor how is going on.
So it's a 5
people. Yeah.
Well, it's usually 5, so 2 on each side and 1 on the head end. Another important thing is often with heavier patients, when you move the patient, the mattress moves. So one has to be delegated for mattress on the foot end, so that they are keeping the mattress in one position. So for heavier patients, we have the 6th person as well. So pretty much the same.